known to most of you, and he will be properly introduced by Dr. Henry Alabari.
Good afternoon. It is an honor for me to introduce our next speaker, Plenary 4. Our speaker is a consultant, Division of Infectious Diseases, Department of Internal Medicine, Mayo Clinic, Rochester, Minnesota. Professor of Medicine, Mayo Clinic College of Medicine and Science, Rochester, Minnesota. A chair in Community Infectious Disease Practice, Department of Medicine, Division of Infectious Diseases, and Vice Chair, Division of Infectious Diseases, Department of Internal Medicine, the Mayo Clinic. Ladies and gentlemen, please welcome our speaker, Dr. Raymund Razonable.
Here we go. Magandang hapon po. And thank you to the organizers for having me back again. It's always nice to come back to Manila and share some of the experiences I've had in the field of transplantation. So they asked me to talk about viral infections in transplant. So it's a very wide field, but I'm just gonna focus on some of the more common infections that we see after transplantation. These are my disclosures. And of course, all the money went to my institution, not to my pocket. There you go. All right, so the field of transplantation has been with us for almost 70 years now. The first kidney transplant was performed in 1950. Of course, that's the most commonly performed even up to this date. The 1960s saw the revolution of transplantation with the first liver, first lung, first pancreas, as well as heart successfully transplanted in humans. It was at the turn of the century when we started transplanting hands, we started transplanting faces, as well as uterus for those who want to become pregnant. And the reason why they're all successful is because of the work that you all do in trying to prevent and treat infectious diseases. So my objectives and outline for the next 30 minutes is to discuss basically later infections. And, oops, can you go back one more slide, please? There you go. Discuss why some of the community-acquired infections that generally don't cause much disease in healthy individuals, why do they cause too much burden in the transplant recipient? And finally, what are the advances in some of the chronic viral infections such as hepatitis C, as well as HIV, that has allowed organ transplantation to be successfully done in this patient population. There we go. So why do viruses, which in medical school, when you say viruses, it's usually benign, self-limited, no treatment, no antibiotics for it, right? But why do they cause so much morbidity and occasional fatality in transplant recipients? And it all goes down to the T cells. So the T cells are basically essential in viral control. So when a virally infected cell is exposed or is recognized by the immune system, predominantly by the T cells basically develop into killer T cells that will kill the infected cell, or will develop into a helper T cell that will boost antibody production by B cells. Some will develop into memory T cells, so that when the same virus comes back again, there is an immediate response and it gets controlled. And there's also a role for suppressor T cells. The T cells are important in transplant because these are the same cells that recognize the transplanted allograft as antigenic non-self. So it will recognize the transplanted kidney as well as the transplanted bone marrow as something that it's not part of the human of the person. And because of this is the reason why we suppress T cells in transplant recipients so that the organs that are transplanted basically survives. And these are just some of the different immunosuppressive agents that we use to allow for graft function as well as to prevent graft versus host disease. The impact of that is basically a qualitative as well as a quantitative deficiency of T cells. These are just some of the signaling pathways that are impaired. Like, for example, qualitative defects is induced by your tacrolimus or cyclosporin because of their effect on signal 1, for example, in T cells. The newest drug in this area is belatacept, which basically impairs the co-stimulatory blockade or signal 2. You have your sirolimus and everolimus, which basically impairs the signaling through 3. And the other hallmark drug is basically your mycophenolate mofetil, azathioprine, steroids, and the others. Overall, the effect is it impairs the function of T cells, and it basically, some of them depletes T cells as well to occasionally sometimes very low levels. And because of this T cell defect, both in function as well as in number, we see a host of viral infections after transplantation. As you could see in this slide, the top part of this slide is in solid organs, that's your kidneys, livers, lungs, and at the bottom is your stem cell or a bone marrow transplantation. As you could see, they follow the same pattern. The first month after transplant, that's when your herpes simplex comes. And of course, we learned that it comes during the first month. That's why we give them antiviral prophylaxis to prevent herpes simplex during the first month. The second period is so-called the opportunistic period, wherein many of the viruses, including CMV, herpes 6, some of the community-acquired respiratory viruses can basically cause so much morbidity. And then the later part, that's when your zoster comes into play. So the first objective is to discuss latent viruses that cause opportunistic infections. And what are they? They are basically your herpes viruses, CMV, herpes simplex, and varicella zoster. Can you advance the slide, please? There you go. All right. So what does herpes simplex do? So typically, basically the same, just like what it does in healthy individuals. It causes your stomatitis, ulcers in the lips, as well as the tongue. And it happens during the first month. While most of them are just basically ulcers and vesicles, there are some wherein it could disseminate and cause hepatitis, for example. And the treatment and prevention is with the use of acyclovir or valacyclovir or famciclovir. And for the prevention of herpes simplex in solid organ transplantation, we give acyclovir in our center for 4 weeks. For stem cell transplantation, we extend acyclovir use to up to a year, mainly to also prevent zoster in that patient population. And treatment is listed below. Basically, duration of treatment is until all your lesions have basically healed. Probably the biggest herpes virus that has caused infection and disease in transplant is basically CMV. This is what's called the troll of transplant. This is the virus that killed many transplant recipients in the 1960s, 1970s, and 1980s. When the CMV gains the upper hand, this asymptomatic, usually benign infection becomes basically clinically manifested, highly morbid, and potentially fatal. These are just some of the slides of CMV pneumonia on one side, gastrointestinal CMV disease on the other side, and the diagnosis is with the use of your biopsy showing the so-called cytomegalic inclusion cell at the bottom. Can you go back one slide? Thank you. So in addition to gastrointestinal disease as well as pneumonia, it can also cause hepatitis, or virtually any organ system can be affected by CMV. But the most common clinical presentation is really just like a flu-like illness, fever, arthralgias, myalgias, sometimes with bone marrow suppression. Next slide. This is the data coming from the Philippines, looking at CMV pneumonia in kidney transplant recipients. Can you go back one slide, please? There you go. And the manifestations really are tachypnea, dyspnea, fevers, X-ray showing interstitial infiltrates, and the like. And when do it happens? Next slide. There you go. It happens during the first 3 months, usually the opportunistic period. And although you can see here, it can happen anytime after transplantation, but most are usually during the first 3 to 6 months after transplant. There's a case fatality rate of about 11%, probably as a result of delayed diagnosis, for example. But with the current era we're in, we have diagnostic testing such as PCR, it can be diagnosed easily. Risk factors is basically a severely impaired immune system. And that's indicated by severe lymphopenia, that's indicated by a history of rejection, that's indicated by the fact that the patient has received the so-called lymphocyte depleting agents such as your thymoglobulin or alemtuzumab. Or just like if there is, next, there you go, too much virus in the system, particularly for the mismatch, as well as different types of transplants such as the lungs and intestinals. So the two most common risk factors in the study that was done here in the Philippines is, this slide set has its own mind, there you go, is having a mismatch status. So being a mismatch, meaning the donor was positive for CMV, the recipient is negative for CMV, that's a high risk for CMV disease after solid organ transplantation, and that's what was found in the Philippines, as well as the treatment for rejection. But how common is a mismatch in the Philippines? It's not. So it's about 2% of all the kidney transplants done in the Philippines is mismatch, but there's a high rate of disease in that patient population. The vast majority of CMV status in the Philippines is positive donor, positive recipient, partly because the Philippines has 98% seroprevalence rate for CMV. The disease in that population of D plus R plus is roughly about 5%. The CMV positive recipient, donor negative CMV has a rate of about 3%. And then for the negative, there's about 5% rate probably acquired from the community. For the bone marrow transplant recipients, the same risk factors, basically a severely impaired immune system, predominantly indicated by lack of lymphocytes. A lymphocyte count of less than 800 is what was found recently in one of our studies, or if the donor is CMV seronegative, for example. And then, of course, if the recipient is seropositive, the patient is a high risk, particularly if they have graft versus host disease. All right. So how do we prevent CMV? There are two approaches. Dr. Panaligan mentioned about prophylaxis earlier, as well as preemptive therapy. Either of these approaches is highly effective. And what are the drugs that we use? Valganciclovir is what is preferred, at least in the United States. Here, I think you also use valacyclovir at a high dose. There's a new kid on the block called letermovir, which has been approved for prophylaxis against CMV in stem cell transplant recipients. And those are the two strategies that are as I discussed. This is letermovir, which interferes with the viral terminase complex, and this is the study that led to its approval in the United States, indicating that it did prevent CMV infection in the highest risk stem cell transplant population. Not sure if it has made it here, but even in the U.S., it's not being used often because of its expense. When your patients develop CMV, the treatment still, the backbone is ganciclovir or valganciclovir. Depending on severity, you may use one or the other. Letermovir, the new drug, is not approved for treatment. And then the other two drugs that are approved for CMV, foscarnet and cidofovir, are highly toxic and are reserved only in patients with resistant infections. Treatment is based on clinical as well as virologic response. The one that's also advancing in the field is the use of immune assays in order to stratify the patient's risk for CMV disease as well as to guide treatment durations, so-called CMV IGRA. Like we're familiar with TB IGRA, there's also now CMV IGRA being used in practice. In our center, we develop a T-cell immune competence score, wherein we basically assign a score to a transplant recipient, and when their score is low, their risk for CMV or tissue-invasive disease is higher, so we are more aggressive in managing them. Okay, so that's CMV. And the third latent virus that comes up is your zoster. This is what we all see, shingles or disseminated zoster, for example, just like the person with the back on the picture right there. The diagnosis is really clinical, but if you're not sure that this is zoster, you can always do a PCR or you can always do the shank smear. Treatment is with acyclovir, valacyclovir, or famciclovir. This is really the area wherein prevention is a key. We vaccinate all our transplant candidates who are susceptible with either the varicella or the zoster vaccine. Thing to remember is all immunocompromised patients, which is post-transplant, the live vaccine is contraindicated, so you have to vaccinate them before they go into transplant. And of course now there's the Shingrix vaccine, which is the inactivated vaccine, which can be used post-transplant as well. And then in the stem cell transplant population, we extend acyclovir to up to a year to prevent zoster in that patient population. All right, this is just a summary slide. Also, just to point out that there's a group of herpes that I didn't discuss. That's your gamma herpes viruses, human herpes virus 8, as well as Epstein-Barr virus. Those are your oncogenic herpes viruses. So EBV can lead to lymphoma or PTLD after transplantation. And of course, in endemic areas, human herpes 8 can cause Kaposi's sarcoma in transplant recipients as well. All right, so moving on to the second objective, which is to discuss community-acquired viruses that cause severe morbidity after transplant. To this group belongs your influenza, parainfluenza, adenovirus, parvovirus, as well as norovirus causing gastrointestinal illness. So they can happen anytime, but they cause the most morbidity during the opportunistic period, which is the second period in this summary slide. And this is what we prevent. We want to prevent in patients with respiratory illnesses. It starts just like a simple rhinovirus, mesipon, konting obo, but eventually will lead to severe pneumonia. So the respiratory viral infections includes your influenza, parainfluenza, RSV, adeno, and rhino. The most common here is your RSV. The most, in terms of morbidity and potential mortality, is adenovirus, as well as influenza. The only one that we have treatment for is influenza and maybe RSV, and maybe adenovirus as well. So it has a seasonal variation. They all present similarly. So it's really difficult to differentiate one over the other. With upper tract going to lower respiratory tract disease. And again, the key risk factor is being lymphopenic or being around children because they carry a lot of viruses as well. It's been associated with increased mortality after stem cell transplant, and risk factors for mortality are progression to lower respiratory tract disease, or the cause is adenovirus. It's more fatal than the others. Diagnosis is clinical, or you can do multiplex PCR to identify what the cause. Prevention, again, this is an area wherein vaccination is key. We want to vaccinate all our transplant candidates as well as recipients against influenza every year. We use the standard dose, but there's data to suggest that maybe the high dose influenza may be even more effective. And then Mario was discussing about hand hygiene, hand hygiene, hand hygiene. This is really the most important strategy to prevent respiratory viral infections in our transplant recipients. For treatment, influenza is treated with oseltamivir, zanamivir, or peramivir. The new kid on the block here is your baloxavir, which is recently approved in the United States for the treatment of influenza, but it has limited data in transplantation. The drug that we use for respiratory syncytial virus is ribavirin. There's a big debate on whether you can use oral ribavirin or inhaled ribavirin. Inhaled ribavirin is very prohibitive in terms of cost and toxicity, so we use in our center oral ribavirin therapy. And for adenovirus, we use cidofovir. A quick summary on parvovirus. What does it do in transplant? It basically causes severe anemia that's refractory to erythropoietin therapy, some cases of fevers, arthralgias, or lazy rash. It's not that common, but if it happens, you'll know it is parvovirus because this is your transplant recipient who comes every 1 to 2 months requiring blood transfusion. If they keep on developing anemia, they require blood transfusions all the time. Oftentimes, we blame drugs, like because Bactrim causes myelosuppression or Celsep causes myelosuppression. Check for parvo because that's one thing that could do severe anemia. Plus, they're going to be carriers, so they're going to be parvovirus infected for a while, and they can transmit it to susceptible host. And treatment for this is IVIG. And that usually kind of resolves the illness. And droplet precautions, of course. I think I'm right on time, all right? Okay. I'm trying to push the pointer. There you go. So, can we go back one slide? There you go. So the final objective is to discuss advances in management of chronic active viral infections that allows for successful organ transplant. And with this, I speak of HIV and I speak of hepatitis C. One slide back, please. There you go. So when I was in medical school, this was non-A, non-B, hepatitis. I just aged myself, right? So, and now we know it's hepatitis C. And for many times, this is basically a chronic condition with no treatment. They progress to cirrhosis, they progress to cancer, or they require liver transplant. So it is the most common indication for liver transplant in the Western world before the advent for direct antiviral therapy. And whenever we transplant livers to hepatitis C infected patients, it leads to accelerated clinical course and allograft failure. But now there's a cure. So there's now a lot of direct antiviral agents that lead to cure for over 95% of patients with chronic hepatitis C. Listed at the bottom are the different combinations, the dipasvir, sofosbuvir, ribavirin, or the cladasvir, sofosbuvir, ribavirin, and those things. And the treatment is for a duration of about 12 weeks, or you can extend up to 24 in some of the regimens. Because of this, we can now cure Hep C. We also now can use hepatitis C infected organ donors. So there's a lot of shortage of organ donation in the United States, but because we can now cure hepatitis C, we are now also using those organs which in the past we don't use, and then we'll just treat the transplant recipient in the post-transplant setting. And there's also now even a group of patients wherein they're waiting for liver transplant, but they get treated for direct antiviral agents, and they get cured, and they no longer require transplantation. So that's how effective the current treatment is for hepatitis C. And then, next slide, HIV. Used to be a contraindication to organ transplantation. Once you have HIV and you need organ transplant, it's a big no-no. It's no longer the case. We are now transplanting HIV-infected patients so long as they meet a certain criteria, such as they should have reconstituted their immunity with CD4 count over 200. We go down to about 100 for liver transplants just because of, pulling into the spleen, for example. They should have undetectable viral load for at least 6 months. They should be on stable antiviral regimen, and they should have no active opportunistic infections at the time of transplantation. The only 3 opportunistic infections or pathology that would contraindicate, at least in our center, for proceeding to transplant is if they've had PML, because PML will come back, if they've had lymphoma, or if they have cryptosporidiosis, because that could lead to severe chronic infection post-transplant. The outcomes has been good. They have a high rate for rejection, partly because probably we are under immunosuppressing them because we're afraid that they're already over-immunosuppressed to start with. The rate for opportunistic infection is similar, just like the non-HIV infected host, and the survival of the graft as well as the survival of the patients remains similar to the non-HIV infected individuals. So it's now being done. It's also now being done into a positive to positive transplantation, wherein an HIV positive organ donor can donate the organ to an HIV positive transplant candidate or transplant recipient. So that's where we're at with the HIV. So in conclusion, we discussed latent viruses that cause opportunistic infections. The main group here is your herpes viruses, and the new things on that group is the advent of letermovir as the new drug that's currently approved, the advances in immunoassays that will better guide us in managing our patients, as well as the availability of the inactivated Shingrix vaccine. We discussed community-acquired viruses that cause severe morbidity after transplantation. Again, the key here is infection prevention and control with isolation precautions, hygiene. In terms of treatment, one may recommend the use of high-dose influenza vaccine, and in terms of antivirals, there's a new drug called baloxavir. And then for chronic active viral infections, we can now cure hepatitis C. We actually can now use hepatitis C infected donors to hepatitis C negative recipients as long as they have the ability to get the treatment post-transplant. And then for HIV, it's no longer a contraindication to transplant. We transplant patients with HIV now, and we also now have been pushing the HIV positive to HIV positive organ transplantation. And with that, I'd like to end the talk, and thank you so much for inviting me again.